Thank you, Dr. Tellem. I have no disclosures. 12 of the questions that were addressed at the consensus conference had type A recommendations voted and approved by the expert panel. Dr. Strasberg has discussed one of those. I am going to briefly summarize 5 of the other questions. A type A recommendation is supported by the current available evidence. This is distinguished, as you heard, from a type B recommendation, which recognizes we have gaps in our knowledge, but does provide an avenue for further investigation. Type A recommendations are further classified according to their strength and the certainty of the evidence. A strong recommendation can be applied to all or almost all individuals in almost all circumstances. A conditional recommendation implies that there's a closer balance of effect. Clinically, a conditional recommendation can be applied to many, or maybe even most patients, but not all patients, and it has to be individualized according to the specific circumstance. The certainty of evidence is determined by the quality of the overall body of data that is available, and it is designated as high, moderate, low, or very low. Question 1 had to do with the anatomic method for intraoperative identification of structures. Should the critical view of safety or another method be used to mitigate the risk of duct injury? The recommendation is that we suggest that surgeons use the critical view of safety for anatomic identification of the cystic duct and the cystic artery. This is a conditional recommendation with a very low certainty of evidence. When the strength of the recommendation is conditional, the language used is we suggest or surgeons may use. When the strength of the recommendation is strong, the language uses phrases like we recommend or surgeons should. This is a summary of the data analyzed for this question. There are no direct comparative studies, and this is not sufficient for a meta-analysis. But there are 2 lines of indirect evidence that favor the critical view. The first is that there are now large institutional studies routinely using the critical view that demonstrate a lower than expected rate for bile duct injury. And combined cohort series that use the critical view have a lower rate of duct injury than combined cohort studies that describe the infundibular approach. The second line of indirect evidence for the critical view comes from studies that have actually looked at the mechanism of duct injury. And these find that when an injury has occurred, the method for identification was not the critical view. Additionally, since the term critical view of safety was introduced some 24 years ago, there is essentially no evidence that its use is detrimental. So if you look at a table that summarizes the judgments used for this recommendation, if the intervention is the critical view of safety, the value of avoiding duct injury is high, the undesirable effects are minimal, but there's no direct comparative data, so the certainty of evidence is very low. However, the balance of indirect evidence and expert opinion probably favor the intervention. It's probably acceptable and feasible, leading to a conditional recommendation for the use of the critical view. Should intraoperative imaging by cholangiography or ultrasound versus no imaging be used to mitigate the risk of duct injury? In patients with uncertain anatomy or suspicion of duct injury, we recommend that surgeons use imaging, particularly cholangiography, to mitigate the risk of duct injury. This is a strong recommendation with a low certainty of evidence. You might ask, how can you have a strong recommendation with a low certainty of evidence? Well, according to the grade methodology, you can have a strong recommendation despite a low or even very low certainty of evidence if there is the potential for catastrophic harm not using the intervention. In patients with acute cholecystitis or a history of acute cholecystitis, we suggest the liberal use of intraoperative cholangiography, and this is a conditional recommendation with a low certainty of evidence. As an additional note, Laparoscopic ultrasound can be used as an alternative to cholangiography for surgeons with appropriate experience. There is a sizable body of literature on this issue. The randomized trials, however, are underpowered for the specific question of duct injury. Most of the meta-analyses and large database studies favor the use of cholangiography. A large prospective Swedish study has showed that the intent to use cholangiography in acute cholecystitis or in patients with a history of acute cholecystitis is associated with a lower rate of injury, and acute cholecystitis, as you've seen itself, is a risk factor for injury. There are repeated studies demonstrating that the use of cholangiography is associated with increased intraoperative recognition of injury and a lower severity of the degree of injury. And intraoperative recognition of injury is associated with decreased mortality from duct injury. So again, if we look at the summary of judgments, although the evidence is low, the balance of effect probably favors the intervention, that is, use of intraoperative imaging to mitigate duct injury. Should subtotal cholecystectomy versus total cholecystectomy done either laparoscopic or open be used to mitigate the risk of injury when patients with marked acute or chronic inflammation? The recommendation is that when there is acute or chronic inflammation that prevents safe identification of the cystic duct and artery, we suggest that surgeons consider subtotal cholecystectomy, either done laparoscopically or open, depending upon the skill set and comfort, a conditional recommendation, a very low certainty of evidence. These are the studies reviewed. There is one comparative propensity-based study. There are a couple of systematic reviews, but the bulk of the literature involves non-comparative case series. But this literature does demonstrate that subtotal cholecystectomy can be performed safely and is a feasible option in selected patients. The literature is hampered by the paucity of direct comparative data, the tremendous heterogeneity of a number of factors, and the low incidence of duct injury as an outcome metric. Hence, a conditional recommendation with a very low certainty of evidence. Next question, should interval or delayed laparoscopic cholecystectomy versus no additional treatment be used for patients previously treated by cholecystostomy who have high comorbidity scores? In low-risk patients, we suggest interval cholecystectomy. In high-risk patients, a non-surgical approach is suggested. This is a conditional recommendation, very low certainty of evidence. A high-risk patient is defined as a patient who is deemed to be at increased risk for morbidity or mortality if they had an elective total cholecystectomy, according to a multidisciplinary evaluation and supplemented by the use of established risk scoring systems. This is a summary of the literature reviewed. The bulk of it consisted, again, of single-center retrospective studies. These studies are plagued by tremendous heterogeneity, and importantly, there's really no standardized selection criteria for patients who either undergo percutaneous cholecystostomy initially or for those who are subsequently selected for interval cholecystectomy. And none has power to draw a conclusion directly about BDI as an endpoint. However, the data does demonstrate that patients who undergo interval cholecystectomy are less likely to have a recurrent biliary event, are less likely to require an urgent operation, are more likely to have a successful laparoscopic operation rather than a converted or an open procedure. And in this setting, a laparoscopic operation is associated with lower morbidity and mortality. Now we're at the last question I'm going to discuss, and this has to do with the environment for repair of a duct injury that has occurred. Should immediate reconstruction by the operating surgeon versus referral to a specialty center be used to manage a duct injury? The recommendation is thus: when a duct injury has occurred or is highly suspected, we suggest that the patient is promptly referred to a surgeon with experience in the management of injuries in an institution with a hepatobiliary disease multi-specialty team. When not feasible to do so in a timely manner, prompt consultation with an experienced surgeon should be considered. This is a strong recommendation, low certainty of evidence, because of the potential for catastrophic harm. This is a summary of the literature reviewed. Case series, not sufficient for meta-analyses. Most studies are hampered by the fact that there is no denominator for the number of patients that may have had successful repair at the index institution, but they repeatedly demonstrate better outcomes with primary repair at an expert center compared to patients who've had a failed repair elsewhere. So the justification for this recommendation is based on the complexity in assessing the extent of these injuries and potentially in the complexity of repair. And it is felt that most patients will benefit from expert referral, and that compared to the limited undesirable effects, the balance of benefits would strongly favor the intervention, i.e. expert repair. So, ladies and gentlemen, that is a summary of 5 of the type A recommendations that came from the consensus conference. Thank you.